Good day, everybody. For those of you who are joining us from Europe, good morning. And for those of you who are joining us from other localities in the world, good afternoon. My name is James Liu. I am the International Marketing Director for Reach Surgical. And on behalf of Reach Surgical, it's a pleasure and an honor to have you join us today for this first instance of our Reach Experience webinar segment. And today we're very honored to count with the presence of Dr. Jerome Dargent and Dr. Pierre Blanc, both well-renowned surgeons from France. And then they're joining us today to share with us a little bit about their experience, not only from the French and European side, regarding bariatric surgery, current perspectives, and the situation in light of the current COVID pandemic. But they will also share with us a little bit about their experiences using our products in their practice and also as part of the clinical research study that we did in France and we completed just a couple of months ago. And they will also share with us a little bit more about the trip, some tips and tricks from the French surgeon perspective, and hopefully, it will be a very informative and a very, very interesting session for all of us. So without further ado, let me invite Dr. Jerome Dargent and have Dr. Dargent start with his presentation. Dr. Dargent.
Thank you very much. I'm very glad to be here. Of course, all of us would have wished to meet face to face, but it's not possible at the moment. As you realize, it's unfortunate. We have to deal with this situation. It's pretty much difficult for us dealing with bariatric patient, bariatric industry, etc., because it's very frustrating in many respects. Hopefully, we'll get over this quite soon, by the end of the year, I hope, unless bad news come out. But it's very difficult to foresee what's going to happen in the next month. But I wish the best, of course. All of us are prepared for the worst, but we hope for the best. And I guess, at least in Europe, the situation is pretty much better than it used to be just a couple of months ago. Unfortunately, there are many glitches along the road, and you've seen what's going on in Brazil, in Northern America, etc. So that we have to be very cautious, but at least what we shall try to tell you about with Pierre is the current situation in France, which is not so bad at the moment. 1 month ago, it was not the case, but now it's quite okay with bariatric surgery, meaning in one respect, at least, we could resume bariatric surgery almost normally. I wouldn't say entirely normally, but it's almost normal, and Pierre, I guess, will concur with that. And it's a good thing because patients are coming back. They have more than ever wishing to have the procedures. And of course, we have to take some elementary caution because of we have to, there are things I will tell you about in more details, but about that. But we have some restrictions. We have to take into account some restriction. But still, we can operate as much as we did almost. I mean, as the patient, the waiting list is going down. So I wouldn't say the year 2020 will be like 2019. Of course, that would be a lie, and you wouldn't trust me if I said that. But I guess we will do maybe 60% of what we did in 2019 in 2020. That's my assumption at the moment. We'll see about that. So let's go into the presentation. First of all, apologies because it's a French meeting. It's, French are sometimes accused of not, assuming that they are the only persons in the world who are doing a good job, but that's not the truth. Hopefully we will give you another feeling than this one. Nevertheless, we have good opportunities in France. The first of them is that we have good numbers. France has always been the leading country in Europe in terms of numbers. It's not because we are better than the others in Europe, not at all, absolutely not. It's because the social security is providing for most cases. So most patients can be reimbursed in France. It's not the case all over the world. We know that pretty much. For the time being, we are fortunate to have this kind of let's say, agreement with the health authorities, so that we can operate, I wouldn't say as much as we wish, but at least in a fair number of patients, and the waiting list is not so big. So the average waiting time for a given patient is about 6 months, which is not so big. Of course, it's a little bit faster in private practice than in public practice, but I guess if you compare that to the UK, for instance, or even Germany, or Italy, or Spain, we are able to do, for a given population, 3 or 4 times more patients than they do in these countries. It has changed a little bit for a couple of years, for maybe 1 year, because we have to file an application that is more strict than it used to be for each given patient. And there is more vigilance from the health authorities to check this out, particularly the older patient and the patient who have been operated on before. So we have more strict procedures for that. Nevertheless, we still can operate as many patients as we wish, or almost as many patients as we wish for the time being. And of course, we have entirely stopped for a couple of months, from March 17 to May 11, exactly, we stopped bariatric surgery. I guess it's pretty much all around the world. Situation has been comparable to that. We have been able to theoretically resume surgical activities starting May 11, but at that time it was not bariatric surgery, meaning most of us, even bariatric surgeons, we choose not to operate right away bariatric patients. We waited a couple of maybe 3-4 weeks. So I resumed bariatric surgery personally 3 weeks ago. I guess it was more sensible to do that because, you know, we didn't know what would happen with the COVID epidemic. So we had to be cautious. So in the first place, we resumed just ordinary surgery, hernia repairs, cholecystectomy, etc. But for a couple of months, we only did emergencies, you know, cholecystitis, appendectomies, etc. Okay. So, I mean, we've been asked by the government precisely to stop all non-urgent surgeries, and of course that included bariatric surgery and plastic surgery. For instance, as a consequence of bariatric surgery, we had to stop that precisely March 17 to May 11, and then we resumed slowly. Let's say 50% basis was the good number. And now, I guess at the moment, it's more like 60, 70%. Our society, the French Society for Bariatric Surgery, called SOFCO, Société Française et Francophone, French-speaking and French society, for the surgery of obesity, chirurgie de l'obésité, and metabolic disease as most bariatric surgery. Our society issued... allô, je peux pas trop te parler, oui. Ah, c'est pas moi là. Non, c'est pas moi qui m'en occupe de ça. Madame, non, oui, c'est le docteur Dargent là. Non. Ben, j'ai pas de patiente avec Mme Canef, non? Non, 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 non. Voyez le calcul, puis je suis pas jeune, excusez. And we issued guidelines because we had to, of course, issued guidelines. Several guidelines have been published in the literature. You've seen that in the JAMA, etc. The French, the International Society for Metabolic Surgery has issued guidelines. So we did that, of course, and I will get back to that in a few minutes, so that we could resume bariatric activities in an orderly manner. One of the key things is that for now, and I guess, I don't know if it will be mandatory till the end of the year, but at least till the end of the summer, that each patient having a bariatric surgery, as well as most important surgeries, except, for instance, hernia repair. We don't do that for hernia repair at the moment, but we did a COVID PCR test 2 days before surgery, not 3 days, not 4 days, not 1 day, 2 days. That's, I guess, it's pretty much international. All right. So this is the document we issued. It's been published now in the French journal, etc. It's not international, and there's no English translation, by the way. But anyway, at least the title has been translated. It's a SOFCO guidelines. Okay. So we had to do that. I guess many countries did the same. So there was some difficulties arise, of course, because what should be the choice of patients? Which patients should we operate on first? Should we even say that some of these patients should not be operated at all during the pandemic or the end of the pandemic, so to speak, if we assume that there will be an end to this pandemic, and which are to be postponed, I would say, indefinitely. This was a conundrum. What should we do? I mean, each country has made its own decisions. If so, issued guidelines that are not very precise in this respect, because on one way, you could say, and people say, and they argue that, of course, obese patients are at risk. First of all, they are at risk of having a COVID, of course, more than the others. And when having the COVID, having more risk of acute and severe complications because they are obese. So this is one reason to operate on these patients, because so that it could be, so to speak, protected against the COVID. That's one way to see. The other one is that some people argued, and I guess some endocrinologists in our country argued, that if you have the COVID and you are recovering from surgery, for instance, having a weight loss, that's important. You know, first month post-operatively, second month, you lose 10 kilograms, then 5 more, etc. So you are more at risk of developing COVID and a severe form of COVID if you are within this stage post-operatively. Some people argue that you shouldn't operate because of that. So we have to find a mix between these statements and organize things so that patient could not be in harm's way, but in the meantime could benefit from weight loss. So this has been an issue. So should we operate first the patient who are more at risk, meaning the fragile patient, or on the contrary, should we not operate on this patient because they are at risk and they will have problems if they face the COVID? So it was difficult. So that I would say that most of the recommendations that have been published in the world are sometimes difficult to read and difficult to understand. I must admit that, and I have no more solution than you. I mean, I'm just the plain surgeon in this regard. I don't know what to do exactly. So the feeling is, from my perspective, and maybe I shouldn't say that loud in public, but is that the most motivated patient, the one who are really asking for, begging for surgery because they want to be relieved, because they gain weight during confinement, for instance, they are the more inclined to be operated on early. So maybe I shouldn't say that. It's you know, it's not, maybe it's not the right thing to say, but that is more or less how things happen. If you have a patient that has a lot of very severe comorbidities, for instance, a cardiac situation, maybe you will take more caution. And that's what we did. We postponed some of these patients, but in the end, they will be operated on in August or September, provided, of course, there is no resurge of the epidemic. And that's our behavior. I don't know if Pierre will concur with that, but that's what we do. And in the meantime, the patient who are the younger one, willing for surgery with not so many risks, are of course more interesting candidates right now because of the situation. But we shouldn't exclude patients with diabetes, etc., for a long time, because it's not something you can stand from an ethical point of view. Of course, provided there is no resuming of the epidemic. And in the meantime, the government, especially in France, has issued some recommendations that are more than recommendations. They are almost orders. And the first one is to spare the drugs for anesthesia. So that we are given a limited amount of drugs for each week in our hospital, for instance. It's the same everywhere in France, almost the same. So they are storing drugs because, of course, you know that there might be some shortages for drugs from propofol, for instance, to get the patient asleep and to get the patient on the Cura, and so that we have limited amounts. So we are obliged to operate at 50, 60% of our capacities because of that. That's number one. Number two is that we cannot have as many, for instance, we cannot use double bed rooms for our patients. So this is one other limitation. In hospitals, in public hospitals, it's even more than that because they have a problem with the staff, especially sometimes the anesthesiologists, the reanimators that have been discharged or are on leave because of the disease, or because of the situation in hospitals is more. I guess the capacity would be, but it's just an estimation. I'm not sure of that. Would be 60% of surgical capacities in private practice. It would be 40% in public hospitals. But it's really something I didn't check because it's complicated, but let's assume it's around that at the moment. So during, of course, and I guess pretty much everyone did that because they were, of course, obliged to comply with the rules and because the patient were not in a hurry to be operated on. So during the period of strict isolation, only emergencies have been performed. Of course, there's always exceptions and glitches, but by and large, people have complied with that. We do just a small fact that we do the PCR, but we don't do the blood samples. I'm a little bit concerned about what my fellow physicians, biologists say, that they do not really rely on the blood tests. And I'm concerned about that. I don't know what the experience in other countries, but we are not very fond of that. We don't even know if the patients are protected with the antibodies they have in the blood. And we have some concerns about that, but I don't know. It's not up to me, of course. It's a larger issue than surgery, of course. And of course, if we didn't have any COVID plus patients waiting for surgery, they should be excluded for another month. That's general recommendation, but we didn't have the case. So that's the general issue, that one must favor short hospital stay or even better outpatient procedures. That's more easy to say than to do, but basically, yes, if you have a band to remove, for instance, it's an outpatient basis, you will do that. You don't have to put the patient on a waiting list for that. But if you do, you can do. There's no reason why you should exclude bypass from your current practice. I guess most of you will agree with that. So that in this regard, there's not so many differences from what we did before. Of course, we always favor short hospital stay, and sleeve gastrectomy, I know in many countries it's an outpatient procedure. We try to do 1 day, sometimes 2 days, but it's still a short hospital stay, whatever the case and whatever the pandemic situation. So it doesn't change much. Of course, if we have, as we try to have not so many patients in the same time in a given hospital, in rooms, etc. Visits are not allowed for the moment. It's not so easy to do that because some patients, they absolutely require to have someone from the family to be close to them. It's not so easy. I had to deal with some so I'm always inclined to be indulgent and to indulge patients and have them have their parents or husband and wives coming. But in my hospital, sometimes it's a fight because people from the staff will disagree with that. All right. Patrick, questions are after that, okay? Or not? I don't mind to be interrupted, but it's up to you. Okay, let's continue.
I think after your presentation.
Okay, let's continue. Because sometimes I like to have a feedback from the audience because I don't wish to say some stupid things, but anyway. Okay, so that's the statement that's inside the French guidelines is this one. One must favor patients with important need for surgery, but low post-operative morbidity risk. That's a weird statement, if you, I guess. It could be a contradiction, of course. If you have an important need, you may have more post-op risk. So everyone has to handle with this statement the best way he can. It's not so easy, but nevertheless, it comes down to the fact that some patients are eager to be operated on soon and some not. But believe me, in the case of obesity, and I guess Pierre will concur, all of you might concur, there is almost no patient asking for waiting more at the moment. I didn't see any. Say, okay, let's maybe a couple of patients saying, okay, let me wait for till September, October, because I have to think about. No, it's very rare. I mean, most patients, they are eager to be operated and as soon as possible. Some of them, many of them, you know, there's been a French inquiry, I've been published a few days ago that said that on an average, I guess they tested, they included about 40,000 patients. 40 patients, every ordinary citizens. And the mean gain weight during confinement, during this 2 months of confinement, 8 weeks in France, has been 1.6 kilograms on average. So whatever the status of the patient, lean, fat, etc. So that most of my obese patients, during the confinement, they gained 2, 3, 4, 5 kilograms. So they are more eager to be operated on. Sorry, I guess. And there's something important that has been taken into account in the French statement is that the literature already tells us, and that is a publication from 2015, that while you are on a waiting list, you not only you gain weight, but your comorbidities get worse. So that you can die because you're waiting for surgery. Just the way, but I mean, it's a remote comparison. I don't want to overdo it, but as you are in the waiting list for a cardiac transplant or a kidney transplant, you're more likely to die because of that. So we shouldn't exaggerate this statement because, of course, it's not the reason why you should rush into surgery because patient will die because they don't have this surgery. So let us no panic, of course. But this is one reason why we strongly stated that when resuming surgery, and it's a big issue in public hospitals, for instance. In my colleagues, my friends from public hospitals, university hospitals, for instance, they always say to me that they're fighting with colleagues, with cardiac surgeons, thoracic surgeons, cancer surgeons who say, okay, my patients have priority. Your patients, they are obese, they can wait. You know, I'm overdoing it. But nevertheless, there's been a strong tendency to say, okay, there's a priority list. But in the end, I guess in almost all specialties, it came down to that. You shouldn't say, okay, your hip replacement is more a priority than your abdominal surgery, or vice versa. So because otherwise it's a continuous fight and nobody wins. So that each specialty, each surgeon should say, okay, this among my patients, this one I should operate on earlier than this one. That's it. And you don't have to interfere with other specialties and say, okay, you are doing a gallbladder surgery. Okay, let's me do mine before yours, etc. It doesn't mean anything. So it doesn't have any sense. All right. So we took this into account, but of course, and also the fact that you while on the waiting list, if you have a COVID, you're more likely to have severe complications. This has been proven. I guess there are many papers out there that say the same. I guess one of the first papers saying that was from Wuhan. It's been published in JAMA, I guess. Patrick will concur. So that we know for a while, and we know from China that when you are obese and overweight, even young, you can die of COVID more than anyone else. So it's this one more reason to have the patient lose weight. But of course, in the theater, what we are doing is just, I mean, I guess it's all over the world as well. You have to special mask because the COVID is likely to be secreted during in the smokes. So it's been said, or laser, or even in endoscopy as well, because of the high pressure systems, etc. So all patients are extubated on site. I mean, in the operative room, not in the recovery room. That's general caution. Low doses of drugs. Sometimes in the beginning, I remember 3 weeks ago, we had patients who were awakened every 5 minutes because the drugs were so low that it was an issue. But so, okay, we spare drugs, but there's a limit to this sparing drugs because we need patients still being relaxed during surgery. That's the minimum. The smoke issue, etc. All right. Maybe for the companies, I don't know if you guys are doing that, but there are companies who are doing smoke recycling devices, and maybe these companies will thrive during this crisis. I don't know, because it's a good idea to have all these smokes recycled during surgery so that it doesn't go out there in the room. Getting in touch with patient. I know, Patrick, you are keen to have some information about that. How do you do that at the moment? In the first place, I guess 1 month ago, we were very keen on having every other patient doing a consultation online. So like we do today. I'm not particularly fond of that because one of the reasons is I never have the right height and the right weight because patients have measured that themselves, and we know there's always an error when they do that themselves. And when face-to-face is much better, of course, especially with patients I never met before. But some patients who lived a little bit far away from my hospital, of course, it was much better. Older patient, why not? I mean, teleconsultation is way better than nothing. Nevertheless, I'm not particularly inclined to do that on a continuous. Although I know I'm maybe old-fashioned, it's recommended to continue to do that as much as possible. Well, let's say I'm not a big fan of that, but I mean, my opinion doesn't count more than anyone else. Of course, this was one way, and we must insist on the follow-up, because if we don't this is one way of doing the follow-up properly. If you don't do that, so let's insist on the follow-up by and large, because the patient need some, there are vitamin issues, there are supplement issues, and possible complication after surgery, etc. You have to do that properly, even in this time of pandemic. But this has been stressed by many other specialties like cancer, etc., or diabetic, etc. You know well that I have friends of mine who are doing cardiology, who are doing neurology. They say they didn't see any cardiac infarction, any brain injury, etc. for a while, and they wonder why, and this was an issue as well. In the meantime, patient selection, patient education, decision making. Has it changed? Yes, of course, it has changed for a couple of months. Then, has it changed in what we are doing now? I guess the input of everyone will be welcome, but I don't think so. I don't think so. There are not so many changes in regard of what we should do in terms of preoperative screening, education, selection, etc., decision making. It didn't change much. So that yeah, I'm a little bit confused. I don't know if it should change or it shouldn't. I would say more caution, of course, more attention paid to this patient, but not more than that. In terms of redos, for instance, this is another issue. Many people have advised caution in terms of redos, not to operate it too soon on early patients. Vous entrez dans le bureau? Oui, entrez. And I don't know, I have a lot of patients who had former bands, for instance, and they have to be operated on, excuse me, I have to give some keys. And so far, I didn't exclude them. Patient who had a band and who needed a sleeve or a bypass, I didn't exclude them for surgery. I didn't postpone them because most of the time it's not a more difficult surgery than primary cases. So I assume if you have a complex patient who had I don't know, a bypass and you need to, for instance, increase the size of the limbs after the bypass, it's a complex surgery in a way. Maybe you should postpone that, but I'm not even sure. Secondary plastic surgery, of course, you may say it's absolutely non-urgent, but still, I'm doing some now. I'm restarting to do that. Maybe I waited a little bit more than the other patients. So, well, this is one of the issues. Another issue, of course. So changes in decision-making, patient selection. My answer is not really, but it's open for discussion. Of course, I don't pretend to be an expert in these matters. Absolutely, so okay, it will be open for question after that. And the choice of procedures, I don't think so either. Should you prefer, if you have a patient that, for instance, he doesn't know, you don't know, and he doesn't know if he wants a bypass or a sleeve gastrectomy. I would say, does it change now? I'm not sure. Open for questions, or for other alternative solutions, but I wouldn't say that. Maybe I change my mind in a few weeks. I don't know. So far, people who have been selected for a bypass will have a bypass, and people who have been selected for a sleeve will have a sleeve. Then more general question, maybe more interesting question. Do we move? Should we move? That's not for the immediate time, and not even for a couple of months now from now, but in the next future, I mean next year, for instance, or in 2 years, or in 3 years. I guess it's the same kind of question that everyone asks itself in terms of society, companies, governments, etc. Should we move to something that takes more into account environment, for instance? So should we say that we operate on too many patients, for instance? That would be a debate. Of course, I don't think so, but some people would say you should favor less aggressive strategies, of course, and non-surgical strategies. Obesity prevention makes more sense in this world now than it made a few years ago, for instance, because you cannot deal with the obesity situation worldwide just with surgery. That's obvious. And surgery is expensive. Surgery is demanding in terms of training, in terms of education. You need to have the staff prepared, etc. So and in the end, you can view this. I don't mean that I'm right in saying that. You can view this as resources waste of time and energy and money, etc., because of surgery. Whereas if you have a very strict strategy of containment of obesity on a public health scale, it would be better than investing a lot of money in surgery. This question I asked, I don't say I have the answer at the moment, but some people could, like just the way that people in France, for instance, are just advocating to have, some people in France, not everyone, of course, maybe a minority, that to say to have less cars and less speed on the highways, etc. These are important notions at the moment, of course, less driving in the streets, and so far. So in this regard, why not more support for innovative techniques? Let's move on more rapidly than we used to. Je peux pas vous répondre là, je suis en pleine conf. Or, on the contrary, move towards more support for classical procedures. So let's stick to let's stick to what we know. Let's stick to surgery as it is. And that would be another option, of course. I don't have the answer, again. What about endoscopic procedures? So on a personal level, I'm a believer in these techniques. I believe they represent a large part of the future. Should we invest more? Should we do more? The training maybe is more easy than the training in surgery. So we could have more patients for lesser cost. So it could be interesting as well. Then I know it's a tough question as well. I mean, why not? I don't have any taboo, but you know that in China, for instance, and all the East, the Far East, and even the Middle East, the big issue at the moment, of course, it's a worldwide issue, but I guess it's more sensitive in the East, is metabolic condition, metabolic disease, and metabolic surgery. So while insisting on metabolic surgery, you increase a lot the range of patients that should be included into surgery, the number of candidates, because everyone knows that in India, for instance, I say India maybe is the most representative countries in this regard. Maybe you will disagree, but I think pretty much everyone agrees with that, and China as well, that the average BMI for metabolic surgery is lower than in the Western countries, because patients get a metabolic condition with lower BMI than they get in Western countries. So it's not rare to operate on a bypass with a BMI 32, whereas in Europe, you would operate on a metabolic patient with a BMI more than 35. But this is a lot, many patients, and you cannot cope with all these patients. It's not possible. So this is another issue. It's also an environment issue, and it's public health strategies, etc. I guess so far there is no restriction for these patients, but who knows? So again, I don't have any solution. It's just I'm pointing out a discrepancy that could be potentially to be debated anyway. So again, more support perhaps for preventive measures, and less. I'm a little bit provocative when I say that, so don't stick to my words, but maybe less support. I don't know. The way authorities, public health authorities will move towards that, but maybe less support for aggressive surgery and more support for prevention. I guess you can do both in the same time. That would be a good way to rationalize that and to cut a deal and have compromises. Still, I'm just thinking out loud. I'm not giving you any solution or any I'm not assertive when saying that. Absolutely, believe me. So what's going on in France in terms of numbers? I say mostly before the epidemic. And I guess there will be, of course, a gap in 2020. That's obvious. Let's hope that 2021 will be almost the same. We have established a registry in France 2 years ago. That's a good thing we did. I guess maybe we are late behind many other countries, very late behind the Netherlands, Belgium, and the northern countries, Sweden, Norway, etc. So we are very late behind them. We are not late compared to Spain, Italy, and even Germany or England. And given the problem, the excuse we have, if I may say, is the fact that we have larger numbers. So getting hold of all these patients is difficult. We try to have this registry mandatory for at least all accredited centers. It's not so easy. Even that is not so easy. Still, we managed to have maybe in 2018 and 2019, roughly 30% of the patient in this registry. It's not enough. It's not enough. We should have at least 90%, but so far it's 30%. I can tell you that in France, there are more than 500 centers doing occasionally at least, or more than that, bariatric surgery. It's way too much. Everybody says that because half of these centers have less than 30 cases a year. It's not enough. And a lot of these centers have a lot of cases, but eventually there are many patients operated on in hospitals with very limited experience. And that's not so good. We're not very proud of that, absolutely. Still, there are among these 500 centers, meaning 600 surgeons, something like that, because there are many surgeons, sometimes training surgeons, etc. 145 surgeons contributed to this registry, meaning roughly 70–80% of the surgeons who are really in charge, people doing more than 100, 200 cases a year. These surgeons, most of them, unless they have any kind of restriction from their hospital, they are inside the registry. So that's 100 hospitals contributing, whereas there should be 400, but just more than that, because these hospitals represent the best hospitals doing this kind of surgery. So, well, we would say that 1/3 of the patients are captured in this registry. It's supposed to be compulsory for the patients who are, for the surgeons who are members of the French Society. The head of the pilot committee is François Patou from Lille. There's a government structure, funding source. So far, is it fortunate or not? I don't know. It's been funded by two companies, Medtronic and Ethicon. I don't know if it will last forever. Is it something to wish that it lasts forever, that companies found this registry? I don't know either. If we rely on the government funding, it's not so easy as well. So, okay, here we are. So, sorry, I didn't translate the slide, but you see that, of course, not much surprise. Not much a surprise that sleeve, of course, comes first. 50%, 50. I guess it should even be 60% now of the operations. And then you have patients converted from a sleeve from a bypass to from a gastric band to a bypass. You know that gastric band has been very popular in France for a while. It's no longer popular anymore, but it's a worldwide issue. But in France, it's been popular for a longer time than in other countries. Bypass is still out there, still 20% of the patient. But in France, there's been an issue 2 years ago, and I will maybe come back a little bit about that. Omega bypass, one anastomosis bypass, or omega bypass, has been, I wouldn't say forbidden, but it's not reimbursed anymore, so that it's basically not allowed anymore. For the time being, at least. So we don't do any omega bypass for maybe 6 months ago. It started 6 months ago. So personally, I did some, but I switched to the Rhonai gastric bypass because of that. It's okay. We do that. So banding is very tiny minority of patients at the moment. Of course, there are redo patients. You see a lot, band removal, conversion from sleeve gastrectomy to bypass, conversion from banding to bypass, etc., etc. So these are the numbers for 2019. Again, the same in a chart. You see that. So sleeve and gastric bypass, basically. And band removal for now is a significant part of our practice. All right. So these are the numbers that are included in the registry. Not very interesting, but okay. So one of the good things and bad things about this practice that we have in France. So this is it's been calculated by some epidemiology team. That's 0.8% of the females, not percent, sorry, 0.8 among 10,000 patients in 1997 had bariatric surgery. This number climbed to 13.8% in 20 years. So that you operated more, the numbers of procedures per patient has increased 14 folds in 20 years. So that's a huge increase, of course. So you could say that in 20 years ago, you operated on not so many patients and too many now, but it's, of course, it's a matter of perspective. In the beginning, private practice has been the most dynamic sector for the surgery, 80%. Now it's 60%. I mean, public hospitals have caught up the trend. But you see that 10% of the patients, it's a huge number, are operated on in only six private centers. You don't have that in public practice. So is it a good thing or a bad thing? I don't know. You know that the French system is can be admired or criticized equally because there is almost no waiting list. If you compare that to UK, for instance, there's no waiting list. Basically, for basic surgery, for instance, for hip replacement, for varicosa removal, etc., you don't have any waiting list. So you can be operated on from your gallbladder removal, hernia repair, hip replacement in a couple of months, whereas you have to wait a couple of years, sometimes, let's say 1 year in the UK. This is mostly because, I guess, the private sector is very dynamic and the reimbursement for the patient is the same whether you go to private practice or public practice. The only difference is in terms of fee, supposedly more important in private practice, not really actually, because you have advantages in public practice that you don't have in private practice. So I wouldn't say that the surgeons are better off in private practice, although I'm a private surgeon, but let's say it's about the same. But anyway, the system in general is more dynamic than in other countries. So the downside of that is that in the general population, pay attention to this figure, you have around, in the general population, among 10,000 patients, 8 will be operated on with a bariatric procedure in 1 year. But in Sweden, which is supposedly a country where you operate a lot of patients, it's 7, it's less than that. 6 in the UK, 6 in the US. So contrary to what people think, not so many people, I mean, in proportion, you operate more than in France than in the US. So who would have thought that? It's quite amazing. Nevertheless, there are a lot of obese patients in the US, and many of them, they don't have coverage. So that's an issue. Anyway, they have other issues in the US, as you know, at the moment. In the UK, much less than that, 1.2. So bariatric surgery in the UK, it's almost doomed for the moment. Maybe it's going to change. I don't know. Boris Johnson will take this over. I don't know. And you can assume that you don't have more obese patients in France than in Sweden or than in UK. Of course, you have less obese patients in France than in UK. That's proven. That's a fact. And still, you operate a lot more than that, 8 times more than in the UK. Because of the system, basically, not because of the surgeons, not because of the patient, but because of the system. And Germany is about the same. You operate much less in Germany. In the meantime, of course, if you take into account all general surgery, it's a huge raise. It's not such a huge raise, sorry, because in 20 years, the raise is not so much. 3% of general surgery to 4%. I would have thought different numbers, but this is the real number. So doesn't represent more than general surgery. Of course, you can argue that you do less appendicectomy than you did, etc. Okay, I guess we are a little bit running late. Are we, Patrick, or is it still okay? What time
It's okay.
is it?
Yeah, it's okay.
Well, we're okay. Wait.
No problem.
So this is a registry, by and large, the way it is filled, etc. Not much interest, but of course you can be inspired. So I finished with the first presentation. Do you want to have questions now? Or?
I think we will hold the questions right after Dr. Blanc's presentation, and then that way they can address both your presentation and Dr.
You do everything right now?
Yeah, in the middle.
We finish that now?
Yeah. Right now, I think it's better to have Dr. Blanc do his first presentation.
Yeah, exactly. Exactly. All right.
Yeah.
Okay. Fine with me.
Yeah. Thank you very much for the first presentation, Dr. Dargent. And now
You're welcome.
I would like to invite Dr. Blanc to share with us a little bit about tips and trips from a French surgeon perspective, also day-to-day experience and input of robotics. So, Dr. Blanc, welcome.
Thank you very much. Thank you, Patrick. Thank you, Dr. Dargent, for the invitation. I'm very happy to be here today. It is impressive to be able to exchange with the surgeon through a computer. I would like to charge my presentation, but I cannot because there is the presentation of Dr. Dargent. Jérôme, est-ce que tu peux enlever ta présentation?
Oui.
Parce que moi, je ne peux pas charger la mienne.
Ça y est?
OK.
C'est bon?
OK.
Ouais, c'est bon, je te vois toi maintenant. Ouais.
Tu vois ma présentation ou pas?
Ouais, je la vois moi.
En plein écran?
Pas plein écran, mais...
Ah, alors attends.
You don't have it full screen,
Et là,
Patrick.
Yeah,
do you see plein écran? It's okay? Do you see my presentation in full screen? No?
Not yet, Dr. Blanc, but maybe it's taking a little bit of time to load. Can you see it full screen on your computer?
Yes, in my computer, I see in full screen.
Okay.
Vous pouvez passer maintenant.
And you?
Ah non, vous pouvez pas.
Okay, there it is. Now we can.
It's okay?
Ah, d'accord, je viendrai.
Yes.
Ouais.
Okay, thank you. I'm speaking about the first procedure worldwide, sleeve gastrectomy, my TIPETRIX, and I finish with some TIPETRIX in robotic gastric bypass. Do you see the second slide? Okay, it's okay for you? Yes?
Yes, Dr. Blanc, we can see.
Okay. I am a French surgeon. I am working in Saint-Étienne. You can see Saint-Étienne is near Lyon, in center of France. In my team, we are 6 digestive surgeons. We are 2 bariatric surgeons. You can see my white hair. I am a VTH surgeon, like my colleague Dr. Breton, like Dr. Dargent. We are a laparoscopic surgeon for 20 years and robotic surgeon for 2 years. And we perform approximately, before COVID disease, 300 bariatric surgery per year and more sleeve gastrectomy like in other team. Laparoscopic sleeve gastrectomy are a lot of advantages, you know. This technique is more effective compared to gastric banding, of course. The sleeve gastrectomy is efficient like gastric bypass with 5-8 years follow-up. And compared to gastric bypass, there is less reoperation after gastric bypass. We perform a lot of, for example, laparoscopic exploration for pain, abdominal pain. It's a real problem. The technical advantages, you know, It's more simple to perform, no anastomosis, no mesenteric defect, no foreign material, no dumping syndrome, no malabsorption, and we can explore the stomach by endoscopy. It is an easy procedure. I can say yes and no. Of course, it's easier than gastric bypass. It's easier than duodenal switch. But can we do a perfect sleeve gastrectomy? Perhaps, but it's not very sure. This surgery is more difficult in a Apple Android patient. We use in France, of course, a French position. We perform this surgery with only one nurse on my right. We use for 1 year the 3-dimension vision, and it's a very, very nice vision like a robotic surgery. We use a reverse two-number position, 18 degrees. And it's very important to have a simple installation, a reproducible installation, and we are 2 bariatric surgeons with the same installation. It's easier for the nurse, for the team, and we can see we fix a lot the patient to avoid any slide during surgery. We use 5 ports, 5 trocars, and the first trocar on the midline is approximately 18 centimeters below the xiphoid process before the insufflation. It's always the same technique. We use, of course, different devices to coagulate ultracision or fusion. A liver retractor, we use a 10 millimeter laparoscopic 30 degree and 2 automatic grasper. And we move the camera and the linear stapler between the 15 or 10 millimeter trocars. You know very well the technique there is for us a 4th step, the greater curvature liberation, the liberation of the angle of ease, the gastric division, and we oversaw systematically the staple line to decrease the risk of staple line hemorrhage. In France, the anatomical landmark is the nerve of the Latarjet, and we cut the stomach approximately 6 centimeters from the pirates. Is different in other countries. And the final aspect is like a golf in France. There is a 3 dangerous zone, and the number 3, the angle of ease, the gastric wall is thin. That is why we use blue or gold load. It's very important to see the left cruise and to cut, not to close the esophagus. The most difficult, you know, is the liberation of the gastric fundus, and you can see on the right, after gastric banding, it's very difficult to remove the fundus because this fundus is retroperitoneal. And it's very important to dissect the gastrophrenic ligament. It is the difficult step. That is why the objective is to see very well the left cruise. If you see the left cruise, you remove the fundus. You know, we can use a lot of different devices to do the gastric liberation, ultracision, fusion. Each surgeon prefers to use one device. It's very important to calibrate the sleeve gastrectomy. We use a 38 French gastric tube, and we stopped the use of mid-sleeve because sometimes it's very difficult to remove it through the cardia, and we have a staple already one time the balloon. And during sleeve gastrectomy, we cut the stomach not to close the mid-tube, because in case of stapling failure, it's possible to replace the stapler. My tip is to remove the fundus. You can see on the left, I use a left rotation with my left hand, and I use my grasper to track the posterior wall of the fundus. And after the slide, I have a short video. To be sure to be not to close the esophagus, I don't remove the lipoma on the angle of east, and you can see on the right, I cut approximately 1-2 centimeters about to the esophagus. If we use a staple line reinforcement, we know that the rate of postoperative hemorrhage is decreased. Today, we use systematically a barb suture. We oversew the sleeve gastrectomy staple line to decrease the hemorrhage, and we use a barb suture, absorbable barb suture, Veloc or quill, it depends. We know that the risk of hemorrhage is increased in function experience of surgeon, staple line reinforcement, and be careful in patients with hypertension or obstructive sleep apnea, because in this case, you can see on the right, the vessel is more thick, more hard, and probably in this case, the fusion is not efficient in some case. That is why when we use a device, we place the device perpendicular relative to the vessels, and I don't hesitate to move the caiman or other device. You can see through the number 1 or through the number 2 to be perpendicular relative to the vessels. And in case of difficult cases, man, android, super obese, hypertension, obstructive sleep apnea, I don't hesitate to place clip to avoid postoperative hemorrhage. And to cut the stomach, I use the left-handed technique, that is, I place the stapler, you can see, on the midline, and I move the camera through the 10mm trocar. And in this installation, we avoid any gastric stenosis, we avoid any gastric twists. To perform a sleeve gastrectomy, we use 4 to 6 cartridge, always 4 to 6 cartridge. If you use 8, 9, 10, I think there is a problem during the surgery. On the antrum, we use a green or gold cartridge, and on the rest of the stomach, we use a gold cartridge. In postoperative case, no radiology, no barium swallow. The patient can drink water on the day of the surgery, can start mixed food on the first day on the surgery, and is discharged on the second day of the surgery. And he eats mixed food during approximately 15 days. Alors, the indication, you can also perform sleeve gastrectomy in a lot of patients. Of course, it's the best, the easier surgery in super obese patient. If patient has height risk, like a lot of comorbidities, etc., I prefer to perform sleeve gastrectomy, older and younger patient. If it's a difficult surgery, for example, extensive abdominal adhesion, you prefer to do sleeve gastrectomy. If it's necessary to check the stomach by endoscopy, of course, it's we do a sleeve gastrectomy. In France, there are a lot of Mason-Maclean, a lot of Mason-Maclean with polypropylene calibration. In this case, we avoid to do sleeve gastrectomy because the rate of leak is more important. In our team, the patient participate to the shows of the surgery, of course, but in case of severe reflux or Barrett esophagus, I think is probably a contraindication for sleeve gastrectomy, but a super obese patient with a severe reflux, I'm starting by a sleeve gastrectomy, and 1 year after the primary surgery, we discuss gastric bypass. Of course, we know that sleeve gastrectomy, the problem is reflux between 10 to 30%. In this case, we can perform roux and gastric bypass if medical treatment is not efficient. In conclusion, laparoscopic sleeve gastrectomy is effective, we know. Is more comfortable for the patient compared to gastric banding. That is why in France, the patient don't want gastric banding. Is effective for weight loss and comorbidities, but we have not study with a very long-term follow-up like in gastric bypass. Sleeve gastrectomy is a reproducible technique, not always easy, and we prefer to do the left-handed technique to avoid any problem during the gastric division. Thank you for this first slide, and I would like to exchange with you about robotic gastric bypass. We perform in 2 years 100 gastric bypass, a lot of women. The BMI was 41, and you can see the complication. We have had 6% of hemorrhage, 6% of gastrojejunnal stenosis. It is a problem for us for robotic gastric bypass. We have had 4% postoperative occlusion, and we have had 8% reoperation. The first study, the complications are not in relation with the robotic system. We have had the same complication during the learning curve in laparoscopic roux and gastric bypass. And 80% of the complication has arrived during the learning curve, like in laparoscopic surgery. It's exactly the same technique than in laparoscopic surgery. The difference are the anastomosis. We perform 2 and soon anastomosis because it's easier and it is the advantage of robotic. It's a big challenge for the team, for surgeon, nurse, anesthesiologic. Everybody is afraid to start robotic surgery, and it's very important to have no complication after the first procedure. That is why during, you can see on the right, during the first 20 procedures, we perform only 1 procedure per day in the theater room, because everybody is very tired, and we starting with by easy case, like in laparoscopic surgery, woman, ample body, low BMI with comorbidities. We have an old system, the SI system. That is why we use only 3 arms, and the surgeon manipulates the blue trocars, left hand bipolar. On the midline, it is the camera. On the right end, and the surgeon manipulates hook cadière. And with this technique, 3 arms and this configuration, the nurse is between the legs. It's a very active nurse. She used 2 ports, and she used aspiration, laparoscopic instrument, laparoscopic stapler, etc., etc. And you can see the installation. The nurse is between the legs with 2 tables. You can see also the anesthesiologist is sit like in different other procedure. In 3 dimensions, laparoscopic and robotic, we're working very close to the tissue. That is why it's very important to have small camera movement, and our technique is a technique with never go back. We measure the small bowel, and second, we do the gastrojejunal anastomosis. We close the Petersen defect just after the first anastomosis. We measure the alimentary limb. We perform the second anastomosis, and we close the mesenteric defect. And we do the same technique in laparoscopic surgery. The most difficult in robotic surgery is how to manipulate the instrument. It's not the same movement, and the movement is like a cello player with some wrist rotation, flexible, working in the center. When you know how to use the joystick, you know how to do robotic surgery. With the SI system, the arms are at the patient's head, and it's difficult to place lever retractor. That is why we choose this retractor. Is perfect for bariatric surgery to expose the cardia. This retractor is few used in France, and the anesthesiologist is also very comfortable. It's very important to show the good nurse because it's very difficult for the surgeon to be not to close the patient. It's difficult for the nurse to be alone close to the patient, and it's very important to start the first procedure with the same team, and I progress and the nurse progress if there is a trust between the nurse and the surgeon, because the surgeon is on the console and cannot see what happened around the patient, and the nurse is the vision for the surgeon. The dissection is the same compared to laparoscopic surgery, but we do a larger dissection because the nurse manipulates alone the linear stapler, laparoscopic linear stapler, and it's easier for the nurse if the dissection is larger on the angle of ease, larger of lesser curvature. We don't use the Da Vinci stapler because it's too expensive, and we use laparoscopic on the stapler. And we can use, of course, a RISH. We don't test today RISH because we use RISH only during sleeve gastrectomy, but perhaps in the future we can use, of course, RISH surgical device. The problem after robotic gastric bypass for us is the gastrojejunal anastomosis. And to avoid this problem, we calibrate the gastrojejunal anastomosis, and we perform a 2 centimeter gastrojejunal anastomosis. And on the right, you can see stenosis and a gastroscopy on the first postoperative day to dilate the anastomosis. And the tip during the surgery, if during the blue methylene test under pressure, you see a good dilation of alimentary limb, you have not gastrojejunal anastomosis. If you have not this dilation, it's very important to perform a gastroscopy, an endoscopy during the gastric bypass. It's very important to close the mesenteric defect and Petersen defect. We recommend to avoid barb suture, non-absorbable barb suture, because we have had a lot of postoperative occlusion for 2 years. And today we stop this barb suture. We use non-absorbable running suture, but no barb suture to close mesenteric defect. And it's a final aspect after gastric bypass, like in laparoscopic surgery, it is the Lono technique. Alors, it was for us very difficult because we are vintage surgeon. It's a new technology, a new organization, new movement, new mentality. The patient is alone close to the patient, and some nurse, like some surgeon, doesn't want to use robotic surgery. And the nurse has to learn to manipulate stapler because with our technique, she manipulates stapler. And all the team must learn robotic surgery. There is a learning curve. The 3-dimension vision, there is a learning curve like in laparoscopic surgery. And The learning curve for the three-dimension vision is approximately 15 procedure. To understand the ergonomy in the operating room for the team, 20 procedure. For the surgeon to use joystick and clutch, 20 procedure. And for us, the learning curve for gastric bypass was 30 procedure. You can see the evolution of the learning curve. When you start, you say, I am bariatric surgeon, I am very good laparoscopic surgeon, it will be easy, but no, because you are the first complication. The critical point is 10 procedure. It was very difficult, and it's very important to have a good team to motivate to continue the robotic surgery. After 20 procedure, less stress for the team. And after 30 procedure, for us, no stress for the team, and our learning curve was 1 year approximately. Of course, it's different for young surgeon. Young surgeon is not the same same generation. And for young surgeon, it's more intuitive. It's easier. We recommend to avoid robotic revision surgery during the learning curve because the risk of postoperative complication is increased. Like in our study, you can see 40% postoperative complication in revisional surgery. The advantage about robotic surgery is the ergonomy. We are less tired, more precision, of course, three-dimension vision, and everybody has less pain, patient, surgeon, and nurse. The advantage of three-dimension vision in laparoscopic surgery and in robotic surgery, you improve your dexterity, performance, there is less blood, less tired, the operative time is shorter. It's the same in laparoscopic surgery. But there is a major difference between laparoscopic and robotic surgery. In laparoscopic surgery is better for the patient, but it's very difficult for the surgeon because a lot of surgeons, you can see, has pain, has musculoskeletal disorder. Some surgeons stop surgery because they cannot operate because of musculoskeletal injury. And you can see the difference between open laparoscopic and robotic surgery. On the right, robotic surgery, there is less pain. Only one problem, because of the installation, is neck pain and pain of the trapezoid muscle. And during surgery, you can do mini break, you can do stretch. After learning curve, you operate with relaxation. And it's very important to find a very good chair, like anesthesiologist. Robotic is more precise, and if you understand the movement, you understand the advantages about robotic surgery. On the left, it is the laparoscopic movement. What we do every day, we do in, out, left rotation, right rotation. It's table football movement. On the right, you can see the 6 liberty degrees of robotic surgery. It's a PlayStation movement. It's totally different. And today, everybody prefers to play on the PlayStation than table football. The surgeon controls the camera. There is a very good stability. Of course, the vision is not the same than two-dimension laparoscopic surgery. The degree of liberty is perfect to perform precise dissection, to perform difficult anastomosis. There is no tremor, and the problem during laparoscopic surgery for young surgeon is the depth perception and the eye-hand coordination. With robotic surgery, there is no problem for the young surgeon. Of course, there are some disadvantages. There is no feedback, sure, but after 20 procedures, the feedback is replaced by the vision. There is no feedback. It's better to do traction contra traction. The operative time is the same for us after the learning curve. A sleeve gastrectomy, the operative time is approximately 1 hour, and Roux gastric bypass is approximately 2 hours. Of course, the difference is the price today, but in the future, with different robotic, perhaps the price will decrease. Other disadvantages, you cannot start robotic surgery without training. And during the learning curve, like a sportive activity, it's very important to have regularity, to use simulator, to learn how to use a joystick. And we recommend during the learning curve only 1 procedure per day. It's not intuitive for us, for a vintage surgeon. If you check the publication, there is a few articles, retrospective study, no randomized. A lot of articles come from a single center, only 5 prospective study, but robotic surgery is laparoscopic surgery. That is why there is no difference between laparoscopic and robotic if we compare technique, complication, weight loss, because robotic is just the most sophisticated minimal invasive surgery. About precision revisional surgery, musculoskeletal disorder, robotic surgery is superior compared to laparoscopic surgery because it's more comfortable for the team. Everybody is sitting like anesthesiologists. And perhaps, if we perform on-soon anastomosis, perhaps we will have less ulcer, I don't know. We are less tired, perhaps less complication. It's difficult to perform a laparoscopic gastric bypass with only 1 nurse. We can perform a robotic gastric bypass with only 1 nurse if we have less complication, and if we perform this surgery in day surgery, perhaps it's cost effective. And we can perform easily a smaller gastric pouch. It is better for the restriction, for the ulcer, for the reflux, perhaps. Next year, Professor Bruno from Nancy will start a French randomized clinical trial to check laparoscopic versus robotic gastric bypass. In conclusion, robotic gastric bypass is a standardized technique. We can use classical endostapler. It's more comfortable for the team. It's more precise dissection. For us, the learning curve was 30 gastric bypass. And we know, the world is changing, theater room also. And robotic, what is robotic? It's a laparotomy plus laparoscopy. It is the most sophisticated minimal invasive surgery. In 1995, we said that laparoscopy was the second French Revolution. Robotic surgery is not a revolution, it's just a logical evolution. And you can see the first indication of robotic surgery is today digestive surgery, is not urological surgery. Thank you very much for your attention. Perhaps Dr. Dargent can continue his presentation, and after Dr. Dargent, he will show a video about sleeve gastrectomy. Are you okay, Patrick?
Dr. Blanc, thank you very much for your presentation. Given the time, we have a couple of surgeons who have joined us from Saudi, and then they would like to share their experience a little bit with us. And then after that, I think we will open up to Q&A for the first 2 sessions that you and Dr. Dargent presented, and then we can move on with the rest of the presentation. So if you don't mind, if it's okay, then I would like to open the floor up to Dr. Rami and then Dr. Khaled from Saudi, because they wanted to share a little bit about their experience. So Dr. Rami.
Of course.
Thank you. So Dr. Rami.
Thank you. Thank you for this presentation. Really, we are and placing that you are presenting your expertise in the French and what you have done and what is about the sleeve gastrectomy and difference between traditional laparoscopic and robotic surgeries, which is it's going on even here in the Saudi Arabia. It's robotic. It's started to be in some centers was it's effective for the complicated case, especially they're using in neurology surgeons and neurologist surgeons. So the questions I have to sharing with you and your experience, I saw in the slide, this is a rich company staplers. We know that for a long time we have used the Ethicon or Echelon and Covidian staplers. Are now we can say this is the time to go out from only to these companies to other companies to see while they are the new companies are good and there is as a technical and there is no complication from that. I need your experience for that, especially the rich company here. We have that stapler. So what is your experience regarding to the using a rich? Why also I used for some cases, but I want to hear from you what your experience regarding to the new Chinese, especially staplers.
Jérôme, je commence. The next presentation for Dr. Dargent is about Riche. I use a Chinese stapler for 5 years. Purple, for example, Panthers, and no Riche. And I have the same complication.
Excuse me, doctor, I'm sorry for interruption.
I have the same complication compare the other device like Johnson & Johnson and Medtronic. For me, it's the same stapler, and I have no more complication with the new device from China. And you, Dr. Dargent?
Hello.
Okay, you hear me?
Yes, we hear you.
Yes.
I guess Pierre's experience is very, very special in France because he's a guy, and I admire him. I admire him a lot for that. He doesn't mind. Is not conservative in terms of devices. Many surgeons like me, many others, they need to feel highly confident in the staple they use. So they are not so easily attracted to something else. You understand what I mean? Because the feeling of a device like a stapler matters a lot, very much. There are some contradictions because for me, for instance, the feeling of an energy device is less important. I can use whatever energy devices you put in my hands. Maybe, yeah, Pierre, I know is very confident in the system where you cut, you coagulate and then you cut. I prefer to coagulate and cut in the same time, but no big deal. But the feeling of a device is very subjective. So that this is the reason why we did this study. We'll talk about that in a minute, of course. So I will get back to you with more precise answers to what you say. The fact is, it's not because it comes from China that it's better or worse. It's supposedly better because China has produced a lot of the devices for Ethicon and Medtronic in the past. So they have the background, they have the experience. Nevertheless, what we've seen, and I don't want to praise REACH, of course I'm a consultant for REACH, but when you were at the IFSO world meeting in 2019 in Madrid, unfortunately there won't be any world meeting this year in Miami next year, so it's a sad thing, but that's the way it is. In Madrid, there were maybe 8 Chinese companies. and felt immediately attracted to REACH because they had the background and the fact what was more interesting, and they had more experience and more dedication. But there are other companies. I don't want to cite any name, but by the way, I don't know them. But that's just having Me Too products without the scientific background that's supposedly expected from us, at least. So that there's a lot of things that matter. Not only the fact that you produce a device that looks like a similar device. There's more to it. So the added value of REACH, for instance, is in there, that they study the ergonomics, and they were able to produce a mixture of the good things that you have in the ergonomics of other devices and still being original. But, I tried purple, for instance. So Pierre was satisfied with purple. I wasn't at all.
A lot of noise.
Panther, I don't know. Panther is a little bit more, Panther could be a little bit more similar to REACH. But the fact is, so the bottom line is that there are several kinds of surgeons, surgeons who can use whatever device and still feel confident, and surgeons who feel that if they don't trust the ergonomics. But the fact is, I will point this out in a few moments. The literature is not so easy to interpret. There's a lot of issues out there. A lot of issues. It's a more complex issue than one thinks. Don't you agree, Pierre?
Yes, and REACH is interesting because it's a mixed between Johnson & Johnson and Medtronic device. It's probably an advantage compared to other Chinese device or Medtronic and Johnson & Johnson.
For me, I think the tissue to heal need to be approximate only. And that's what we are getting for all devices. There is any way to check the staplers to be that full fit to make the approximation and a proper and can be examined and during the surgeries can be enough by methylene blue test, or it's a need to be see all B-shape of the stapler to be reaching from posterior to the anterior wall of the stomach to feel that it's enough for us that tissue approximate very well to start the healing within 24 hours.
Jerome?
I didn't get exactly your question. What do you mean by approximation? You mean the tissue should be right away, should be seized, apprehended right away, or step by step?
We know that for the healing process, just we need to be the tissue to each approximated to each others. It does not mean only the tension. That the healing process will go smoothly. If there is any interrupted for the approximation, it will be unhealed tissue. So that's why I'm asking, there is any way to examine that stapler, it's a good, and making that approximation or making the anastomosis, it's intact and effective during the surgery, or like a methylene blue, it's enough for us to examine that staplers, or need another things.
Tissue healing is the biggest issue, of course. It's always been the biggest issue in terms of stapling. But so far, correct me if I'm wrong, but I reviewed a little bit the literature while doing this study, and there is no hard evidence from anywhere that one way of approximating the tissues, because there are several devices out there, okay, and each of them has a different way of stapling. For instance, the tri-staple, the Medtronic system works for a while with a system where the tissues are not crunched in the first place. They are just brought one to another, and then once you start the firing, the tissue gets seized or apprehended or approximated, I don't know how to formulate it, step by step, not right away. Whereas the Ethicon system is just crunching the tissue from the beginning, so it doesn't move at all, and then it's stapling. Well, with the Medtronic, it's the opposite, entirely the opposite. The tissue is not crunched, it's just apprehended. And then the pharynx makes the approximation. So one would say, well, it's much better to do that. And the other would say, no, don't do that. But nobody has the answer. Nobody has the answer. No one has been able to prove that one design was better than the other. So the REACH solution, which is a mixed, seems satisfactory to me. But I mean, neither me nor REACH nor anyone has solid evidence. What should it be? Same with the tree staple. Is it good to have tree stapling with different heights of staples or not? Nobody knows. Nobody knows. Some people say that tree stapling could be replaced, but a notion that's very vague for me. I mean, maybe I don't have any. Maybe I'm running out of knowledge for that. But the fact is, sometimes people say that slow firing is the issue. If you that could replace the benefits of the tree stapling. But I don't know really, and there's no hard evidence for that. The problem is, I will explain to that in the presentation. It's too early to say, but there's something interesting about the literature as well.
Thank you for you.
Can I make a comment, please?
Yes, Dr. Khalid, please go ahead.
Yeah, thank you very much for your great presentation. I have just want to share with you my experience regarding few points. It's actually regarding be liberal and be open to the other companies. I'm so liberal, and I had actually the pleasure of using REACH instruments, and I'm so happy with it. Especially the ergonomics. I like the ergonomics and way the staplers lays. So I'm really happy with it. Regarding buttressing, I used to buttress in the start of my practice. Then with the suturing of the whole suture line. Then I stopped, and then I used to put clips almost in the lower half, suture the upper half. Then I stopped. I used SIM guard, then I stopped. Now I'm just cutting without any reinforcement, except if there is areas of bleeding, I clip it. So there is always evolution in my practice according to the results I see. So this is one point. Regarding the robotics, we are just starting our experience here in Jeddah, and we got the robot. So I would be really eager, maybe in a year time, to share this experience with you. The third point, actually, I want to say that a year ago, we started our single port sleeves. And that which gained really very good repetition among patients, and even they ask for it. The reason is it's very, the cosmetic results, I think it's better. But the problem with it, maybe you need longer instruments. So thank you very much for this nice presentation. And I thought I just want to share with you these comments. Thank you very much.
Thank you, Dr. Khalid. So now I think we just have a couple of more minutes. If anybody has any more questions regarding the first two topics that Dr. Dargent and then Dr. Blanc helped discuss, you can please go ahead. If not, then we can continue with the next two presentations. So if you have any questions, please speak up.
No other question? After the other presentation, perhaps?
Yeah. Okay, if not, then I guess we can continue. So I will ask Dr. Dargent to please talk to us a little bit about the the clinical trial that we had in France and results, and
Okay.
you know how you
Do
saw.
you have it on screen? I have it on my screen. Do you have it?
Not yet.
Well, I have it. So what should I do if you don't have it?
You might need to. Are you sharing the screen, Dr. Dargent?
So option, share the screen. Écran, screen. I don't have this option.
That should be at the bottom of your software.
You don't have it. All right. Because I clicked again on the webinar.
Yeah, you should be able to see on the lower portion the option to share the screen.
Okay.
There you go.
Yes, I am sharing the screen. So if I put that.
C'est bon. Tu mets en plein écran et c'est bon.
Okay, fine. So, no, I'm full screen. Are you okay?
Parfait.
Is it okay for you?
We can see the screen, but not
Yes.
full screen yet.
Ah.
Maybe it's taking a little bit longer. Oh, there we go.
Okay.
Thank you.
Yeah, you are? Okay.
Yeah,
So let me tell you. You have it? Let me tell you about the experience we had in France with REACH, and we just published it. It's online for a couple of days now. So what struck me, and I have a lot of praises for REACH, but what surprised me a little bit, I mean, the first thing I asked Patrick when I met him is, do you have any kind of course you have experience, you have surgeons. I met surgeons when we had this dinner in Madrid, but do you have any abstracts? Do you have anything published? I mean, not mandatorily a publication in an international journal, of course, but at least an abstract from a meeting, because most of the time the abstracts are recorded and you can publish. I mean, you have them for publication and you can hand them out to the customers, etc. But so you didn't have that. So I said, let's do that in France, but at least we should do a study and publish it, at least an abstract, and of course, even better, a paper. So that, because maybe I'm old-fashioned as well, I'm a vintage surgeon, like Pierre said, but I trust what's been published. It's important. If it's not published, you know, I don't mean it doesn't exist, but you need to have at least some background. So this is what we tried to do in France with the help of REACH, and it was successful. We even started from the bottom. I mean, we started with experimental studies on cadavers, because, of course, it was not an absolute necessity, because you already have patients. You're not an experimental device, of course. But for the French market, for the French situation, even for the international market, you need to have strong evidence. And of course, you did that before, because you did patients. And you have the CE mark. You don't have the FDA, but I guess you will have it sooner or later. But we needed to start from the bottom in France in order to be appreciated and recognized by the customers. Sorry, I go through, because the two presentations are one in just one, so I need to finish the other one. Okay. So I just summarized a little bit in these slides the paper, so that I will follow these guidelines. Of course, a lot of it can be skipped, but I will stick to it. So the issue is quite an important one, because stapling is not nothing. Some stapling matters a lot. In bariatric surgery, I've been, in the pioneering era in the 20s, in the year 2000s. In the year 2000, let's say to 1995, 1999, 2000, 2001, etc., the market was small, but 70% of the market was not bypass. It was either VBG, but the VBG, vertical banded gastroplasty, was going down, and 50–60% of the market was banding. So banding is a prosthesis, but banding is there's no stapling in banding. So we moved from this situation, and in 20 years, 90% of the market, 95, 98 perhaps of the market is purely stapling. Of course, you can do some stitches. Most of the part of the devices you rely on for surgery is stapling and linear stapling. Of course, there's always some part with the circular stapling. You know that the pioneer with the bypass did it with the circular stapling, notably the publication of Clark and I don't remember the name. Of course, I know the guy who invented the bypass through laparoscopy did it with a circular stapler. I don't know one surgeon in France doing it with a circular stapler. Do you agree, Pierre? I think nobody does it anymore. So linear stapling for everyone. So 90% of the procedures are using linear stapling. So you rely on a device that's very, very important, because safety is a primary concern when it comes to sleeve gastrectomy and bypass surgery. Because all the problem, 90%, let's say 70% of the problem you will have after a bypass or a sleeve gastrectomy comes one way or another from the fact that you stapled. That's very important. So when you use a stapling, you need to be confident in that. So you need to share experience and write it down and do the right thing in order to assess that properly. We know that for a while, at least till 5 years ago, let's say that, Medtronic and Johnson & Johnson had 99% of the shares. There was almost no one. Then China came out, because China has this huge experience of having been a subcontractor for these two companies. And they were right, I guess. It was absolutely their right to come out and do their devices and sell it. And the fact is that you have a monopoly from two companies is not so good for us, for surgeons even, and for hospitals, etc. You need to have competition. That's absolutely necessary. And competition entails innovation as well. So it's very important. Because of course there was the patent issue at that time, and the patent issue is no longer such a big deal. And of course, companies like yours, they are able to upgrade devices without the help of other companies and doing their own research and development activities. But for the new devices like yours and other devices, there was a lack of data, especially in Europe. Of course, you had the CE approval, but CE approval is not enough. So we did this study. It was an open, non-controlled, multi-center trial. We tried to gather the experience of 5 different surgeons. The initial surgeons were not the one we ended up with, but it doesn't really matter. All the surgeons were seasoned. They had a lot of experience of more than 500 cases for all of them. Even more than that, of course, when it deals with Pierre, for instance, and myself. So we used this endoscopic stapler. You see the references with the Zulu cartridges, etc. So this is the device. Let me remind you a few items. Of course, I'm not the most competent to tell you about that, but this is the issue. I have one sample. Do you want me to bring it in front of the screen? Maybe I can do it a little bit. Just wait a sec. Well, thanks to the generosity of Patrick, I have one there. So you see, I mean, the screen is not so easy to, of course. So you see it, of course, and you see this part of the device. This is very similar to Medtronic. All right. So you do the firing with that. and the grasping and the holding is there, this part of the device. That is locked here, and then you staple with that, and then this goes on, and when you pull that, of course, it opens. Then you have the articulating part that makes it rotate and sometimes bend one way or another. Okay, I'm not, you know, Patrick and will be much more competent to tell you about all these details. But it was, it's very important. When I went to visit Patrick on the booth, it was the first time we met in Lyon and then in Madrid, and I brought my friends to come and visit him. This is the first thing, you take that in hand, and this is the first impression. And the first impression is the most important. So you immediately feel confident with this kind of device. But of course, it's not enough, but it's very important. First sight. So first sight matters a lot. All right. Then, what we did in the beginning was trying that on cadavers. And sorry about that. Oui, je peux pas bien vous répondre. Je suis en conférence, mais. Non, demain. Ben oui, bien sûr. J'ai pas la place aujourd'hui. Demain 8 h. Mais pour le moment, j'ai pas le temps d'en occuper. Je peux pas vous répondre. Ouais, on vous rappelle. Ouais. Okay. So we went to there's a lab at an anatomy lab at the Faculty of Lyon, and so we evaluated that. And the most important, this lab is a training lab for residents. So it was very important to have the feeling of the residents, just the same as we did with Pierre and others when we met Patrick and other people from this company, to have the device in hand and see how it goes. The way you staple, the way you feel it, it's very important. So we took some 3 residents, which I salute and acknowledged for that. So we did 2 cadavers. It was nice and easy, of course. And I got the feeling from these residents, it was very important. All of them felt very comfortable with the device. Of course, they made comments about the difference between this device and the others they have been used to, like, of course, the Medtronic and the Ethicon. One of the key things is, of course, the way you grab the tissues, the way you feel the stapling, the way you retrieve the stapling, and the way you perceive the safety of the device when you just perform the stapling. And above all, the way you have the device in hands, the way it bends, etc. All right. As I said, the difference. So this is the way it went. So you see the staple line was nice. Absolutely. Very similar to the others. Of course, this issue of doing these small discrepancies, these small curves, when you move from one staple line to another one, it's not so easy to do it perfectly. I mean, the perfect staple line is not in this world, I guess. Nobody will ever do a perfect staple line. Doing staple lines that are perfectly in continuity is a very tough job. You know, there's been a webinar recently with Michel Gagné. I've seen that. I didn't attend the webinar, but the title was nice. It was, is it possible to do a perfect sleeve? I guess it's not. Some say it is. I do the perfect sleeve, but I'm not doing the perfect sleeve. The perfect sleeve doesn't exist. I mean, a perfect sleeve, like there, doesn't rotate. So who says it cannot rotate? It's not possible. I mean, of course, you have tricks. Patrick will tell you, Pierre will tell you that. You have tricks to do that as much close to the perfection as it's possible. But it's really, doing it perfectly is not so easy. So, okay, this is what we did. And we did also a bypass. Okay, we did a sleeve and a bypass in cadavers, and the feeling was good. You see Patrick with young residents. He was quite happy with that. Oh, sorry. Let me get back to Patrick. A nice fellow with young residents. All right. Then this is a case, one of the cases we did in the theater. So this is a sleeve gastrectomy. Again, here we'll have much better picture than mine, but we see that what we are used to use reinforcements for the 2 last staple row. So we stuck to that because Patrick told us that it was possible, that it was perfectly compatible with the, in this case, it's a seam guard reinforcement. So we did it, okay? And we can, because it's, and the way you use it, it's similar to Ethicon, the Ethicon cartridge, reload. So we did it the same way. All right, so then we moved, of course, to the real world and the surgical practice. So 5 surgeons, 4 different hospitals, 2 in Saint-Étienne, 17 cases, 5 in Bourgoin, it's close to Lyon, 5 in Toulon. Toulon is close to Marseille. It's the south of France, the southern border, southern sea, Mediterranean Sea, and 9 in our center in Lyon. All right, so it's 36 patients between October and February. So the last case has been performed 4 months ago. So of course, all the patients were treated, selected, and chosen accordingly to what we do usually with social application to the social security, informed consensus, etc., etc. Mean age, mean weight, mean BMI is pretty much the same as in most studies, of course. Numbers of comorbidities, etc. Additional informed consent for the device, of course, not the general device, not the general informed consent, but an additional one saying that we use a stapler that has never been used in France so far. It was very important. And each of us felt a questionnaire for each patient with, of course, the immediate and post-op results. And we asked each surgeon to rate the safety and the ergonomics of the stapling. So it's quite a satisfaction index from 1 to 5. We could have done otherwise, but seemed to us the most interesting thing to do. So each of us should say, okay, it's been safe. Of course, it's subjective. You felt safe with the device for this particular patient, and you felt satisfied with the ergonomics for this particular patient. Of course, it ended up like every one of us did apply the same rating for all his operation. There was not a surgeon that was less satisfied with one patient or another with this device. It was about the same rating. It could have been different, but actually it was the same because a mishap could have happened, etc. It didn't. So the satisfaction index was slightly different from one surgeon to another because when you have to rate ergonomics, someone would say 3 and another one would say 4. You don't know why, but still you have to do that, of course. So there were, we had a small issue with the closure mechanism. If you introduce the cartridge too rapidly, and when you seize the stapler, if you do that, Patrick will corroborate, that is okay. You can do that as much as you want. If you accidentally do that, it can jam the cartridge. So you should pay attention to just move with that and not with that. So when the nurse, for instance, take the thing, give it back to you, and does that inadvertently. So in my operating room, I did it once, and the nurse did it once. So each time Patrick was there, we had to change the cartridge. It's no big deal, of course, but you have to be told before. And I was clumsy, I must admit. My bad. So mean operative time was not different, of course. There's no reason why you should waste time with this device. There was one, Pierre did one case with an open procedure. So we included it because, it had to be converted to laparotomy because of adhesions. So no complication for all the patients except one of mine, Clavien Dindo 3B, meaning at day 4, patient was going back and then he came back for fever, pulmonary infection, and he was treated in an hospital close by who didn't acknowledge anything inside the abdomen. But the fact is, the day after that, there was fever again, despite the treatment for pulmonary infection. The pulmonary infection was not the reason why he had fever. He had a subphrenic abscess, a typical one. There was a laparoscopic exploration. No fistula was recognized at that time, but of course the patient was treated accordingly with cleaning and drains. We must say that the patient has never developed a fistula, a clinical fistula. There has never been a leak that has with symptoms, but he was treated as if he had a leak, of course. The fact is he recovered in a couple of weeks. So he had an operative stay of 2 weeks, and then he went back and he was completely cured in 1 month, and he resumed work in 2 months. So it was okay. Could have been worse, but okay, it was okay. So there's no reason why it should be the responsibility of the stapling. It was more perhaps the responsibility of dissection. I don't know. It was a primary case anyway. So 1 complication in 36 patients, that's less than 3. There were no minor complication in this series. Could have been, there were no minor complication. So the average of the safety was 4 out of 5, and the ergonomics 4.5 out of 5. I was the one who gave the less important rate. I gave 3.5 because I was not entirely satisfied by the ergonomics, etc. Pierre was more satisfied than me, but it was okay, of course. Everybody kept his habits regarding the type of cartridge: blue, green, gold. These cartridges are similar to Ethicon, and we used the same. So I used gold, so I stuck to gold. But some people like Pierre, I guess, or Sébastien in Bourgoin prefer to put the green one in the beginning for the first row. I use gold all along the staple line. And of course, the number of stapler of cartridges was just similar to what we did before with other companies. By and large, it's between 4 and 6, usually 4.5, let's say, on average for a sleeve gastrectomy, for instance. And I used personally reinforcement with SimGuard for the 2 last staplers. Okay, so all of us had experience, of course. So this is yeah, you know, I'm the one who had the less important rating with the ergonomics. Okay, and complications. So this is so some space for, yeah, this issue with the cartridge. I mean, I don't know if it's entirely solved, but it's been improved by Reach for sure, so that it doesn't jam. It's a slight misconception, I guess. It's no big deal. It's also been transmitted to Reach that when you move the knife backward after you fire, it's a little bit stiff. So I guess it's been corrected now. Sorry. There's something else. It bothered me, but not the other surgeon. The fact that when you bend the cartridge, usually I don't like to bend it. So I try not to bend it. But sometimes it's useful, especially when the sleeve is complicated. There's some difficulties in dividing the vessels, etc. So I found that there was a slight elevation of the tip when you bend it, but it's just me. So. For instance, Pierre found that the articulation is a little bit too smooth. Very minor issue, but something, you know, there's always, the feedback from surgeons is very important to companies like yours. I mean, it's very important to say, okay, this is a little bit stiff, this is not, and when everybody says the same, of course, you make the correction. If just one people say, okay, I don't like that, it's not enough, of course. So it's typical consumer producer conversation. All right. So the discussion, and I think there are very important items to discuss. So gastrointestinal or gastric stapling is dominant nowadays. It's not going to change for a while. The 10 forthcoming years, stapling will be very important for bariatrics. That's for sure. It won't go away. So you do not contemplate sensible alternative to that for now, that's for sure. So the upgrades and the safety and the ergonomics is very, very important. The problem is many companies, including Ethicon, including Medtronic, they do upgrades very rapidly. And they launch it on the market. I wouldn't say it's not evaluated before. Of course it is. But when you want to evaluate that on a scientific point of view, meaning doing series, for instance, you have to compare things that you can compare. But the problem is when you have an upgrade from a company every year, which is the case at the moment, it's difficult to say, did I have difficulties because of this upgrade or because the upgrade was not present? It's a very difficult issue. So there's no example of a proper launch of an upgrade, even from Medtronic and Ethicon, meaning that when Ethicon comes out with a new upgrade, it's very, or for instance, let's take a very simple example. 2 years ago, Covidien has decided, Medtronic, sorry, has decided to do its own reinforcement. So in order to compete with SimGuard. So basically, they did their own reinforcement. It's a little bit similar, it's a little bit less expensive, but it's almost as expensive. But there was no testing. There is no publication on that. Nothing, not at all. No paper, no abstract, nothing. So when you analyze the results you have with this reinforcement and you want to compare, for instance, the percentage of leaks with this upgrade and compare it to the SimGuard, you cannot do that because you never know how many patients will have been operated with this one. There's no abstract, nothing. And it's a shame. And it troubles me, actually. Anyway, that's the world. That's the way it is. I cannot do much about it, personally, of course, and even in France. There should be a registry somehow of stapling incidents, etc. There is none available on a worldwide scale, none available in France, in Europe, etc. Once the CE mark has been approved, nothing is going on, nothing is happening. And of course, this would be a huge step forward, but nevertheless, the problem is the feeling of the surgeon, the feeling of a group of surgeons is more important than the actual data. So that when I said that all of us, we went to the booth and we took that and we felt confident, or we didn't, mostly we did. But it's more important for us. Even me, even Pierre, we try to have some scientific reasoning, but even us, we just rely more on that than the data and the papers and the abstracts. That's difficult, but we have to admit, as surgeons, we are human beings when we have fails and downsides, etc. So, you know, the volume of it, the fact that it's bulky or it's hard, it's too long, too sharp, too big, too heavy, etc. That's very important to us. The strength you need to do that. You need one hand or two hands, very important. Because some of us say, okay, I need two hands, too much for me, I don't want to. Or, you know, I do it left-handed. I can't. I do it right-handed. But some of my friends, they are very skilled. They have the skills to do it left-handed. But when you do it left-handed, the strength is not the same. So all this is very important, and that's it. And the fact is, and it's a huge, huge problem, believe me, maybe the most important. You could rely on a simple set of data, which would be, because it's easy to report how many, and it's not, by the way, but it could be easy to report all the incidents you have intra-operatively. So it's easy for a company. It should be easy, but it's not. It should be easy to say, okay, this year we used 1,000 stapler in this hospital. Let's say that. Out of this 1,000, there were 10 incidents, two misfiring, two intraoperative bleeding, anything like that. The staple line formation was poor, failed. So you could that. It's not so easy, but it's not done. But even if you had that, and you don't, even if you had that, how can you you cannot relate that to the actual rate of complication. Let me explain in 2 words. If you have a intraoperative bleeding because the staple line just failed, for instance, so you have to sew again, or you have to do again the staple line, etc., etc., doesn't mean that the patient will have a post-op complication. Most of the time, it doesn't at all, because you coped with it. You just fixed it instantaneously on the spot. But the fact is, you cannot relate this rate of intraoperative incidence to the final rate that you will eventually get had been operated on and had a late complication. So you cannot say the fistula you had is because of the staple line. You never can do that. Is it because of the staple line? Is it because you damaged the gastric wall with too much coagulation, for instance? You never know that. And you cannot answer to that. And given the fact that the upgrades are coming out constantly, continuously, it's even more difficult. And I was hoping to find something in literature. When I studied the literature this last winter, I was hoping to find some data. There's no data, nothing reliable in the literature. Believe me, I tried. I did the Index Medicus, and I didn't find anything relevant. I found a lot of publication, but none was really. Not so many in very important journals like JAMA, etc. Not so many things. Not so many. So I must say, I must confess, I'm disappointed, and every one of us is, by the fact that you cannot really rely on science for judging safety and efficacy of the stapling. So we know little. That we must confess. And there is no reliable study, no reliable registry, so that even companies that are very assertive, like Medtronic, like Johnson & Johnson, are able to produce results and saying, I can prove that my stapler is better than the other ones. Nobody can do that. And nobody is even able to produce results of a given upgrade. Okay, since we use these upgrades, surgeons are very satisfied. What does it mean? Surgeons are very satisfied. They buy the device, of course. Hospitals buy the device. Does it mean that they are very satisfied? No, because there's a money issue as well. They sell it for cheaper price, etc., etc. That's and they negotiate, etc. So, very difficult job. And it becomes even more difficult when you address the issue of staple line reinforcement, for instance. You supposedly know that you have less bleeding when you reinforce. That even is not for sure. But it seems, there seems to be a trend in the literature that says when you reinforce, you have less bleeding. Not even sure of that. But nobody will tell you you have less staple leak. Some people have said that it's been contradicted, especially with SynGuard. So there is no reliable data on that either. So when people use staple line reinforcement, they don't know if you have to. I guess Pierre doesn't use it. So some people use it. Some I do. I still do. I'm not even sure I must or I should. And the causes of a staple line leak are various, and it's difficult to evaluate what was the real cause of that. So you see that I'm very sorry to say that literature doesn't bring you much comfort and much relief. Literature is troublesome. Of course, the ergonomics is important, personal judgment, as I told you, staple line reinforcement, motorized version, of course, should be quite important. Again, no reliable data that says to you, if you use the motor, it will be better. Nobody says that. Ergonomically, yes, I think. I wouldn't say I'm more confident in a motorized version, but at least it says that you can at least you can state that the device doesn't move, the stapler doesn't move when you fire with a motor. That's already something. So it's likely to bleed a little bit less and maybe have to have a more steady firing. But that's all. So of course, motorized version is important, but is it decisive? You don't know. The structure of the staple line, 3 staple, is it important to have different heights of staplers or just the same height? It's a very important notion. It should be very, very important, but you don't know. You don't know. You don't have many data on that as well. I would have thought that back 2 years ago. I thought that it's very important to have a three stapler because the fact that you have a small and then a large, etc. It will make a better healing of the stapler line. But even that we don't know. So in the end, of course, the costs, because we have, of course, there's a tend to do low costs. And you know that back in the years 2012, let's say that, there was a tendency to use gastric plication instead of gastric firing when you wanted to do a gastric division, when you wanted to do a sleeve. So there was a fashion of doing laparoscopic sleeve plication instead of laparoscopic sleeve gastrectomy. And it failed. It failed. So that this low-cost attempt has failed. But then, of course, there's not much to save, I would say. Of course, you can gain 10%, 20%, but it's very commercial, and the companies who have more expensive stapler will say that they are more expensive because they're better, and of course, they will do discounts in the end with different negotiation with hospitals, etc. So low cost is also an issue, but it will always remain a little bit expensive nevertheless, in my opinion. So staplers, you cannot get a staple for nothing. That's obvious. So this is some of the literature. I guess Patrick can forward the paper to you because it's been published. So you have the references I used, and I guess in conclusion, so 5 surgeons, 4 hospitals. We were happy with that. Okay. Nuances, of course, but globally, it was a very positive experience. European experience is increasing. You have sales, reach as sales in Germany, a lot of it, and gaining ground in other countries in Europe. Hopefully, this will move on. Of course, this is not a good year, 2020, but 2021 looks bright, I hope. We will have a vaccine, so be it. Let's pray and hope for the brilliant future. Honestly, efficacy, safety, so far, a match. It's a match. I cannot say it's better. I cannot, of course, I won't say it's worse. It's a match to other devices. That's good. That's good. Of course, we have to watch this closely, especially in France, because it's going to be, you have a rep in France, you have a distributor in France, and we'll have to have a close look to the results in other centers. That's it. Thank you.
Thank you very much, Dr. Dargent, for sharing your experience with the clinical trial with our device. As you mentioned, certainly our exposure in France and then also in some other European countries is increasing. And we certainly hope that the situation will continue to get better as we get out of this COVID-19 pandemic, right? And as you mentioned, 2021 is looking brighter than this year. So hopefully 2021 will be a much better year for all of us. So thanks again. For the last part, I would like to invite Dr. Blanc again to just give us a little bit more of his experience on how to better use the Reach Endo cutter. So Dr. Blanc.
Yeah, thank you. Jérôme, est-ce que tu peux enlever ta présentation?
Yes.
Can you remove your slides, Jérôme? Thank you.
Done. Is it okay?
Perfect. It's okay. Can you see the video?
Yes.
Yes, we do.
Yes, it's okay. Thank you. To finish, I will show you a short video. It's a sleeve gastrectomy. It was not an easy case, but I think it's interesting. Jérôme show you the Reach Endo 3 stapler. It was a man, it was a revisional surgery. I removed the bonding 3 months ago. It was a fatty man, android man. It's a French position, 5-port. Like I said before, it's always the same procedure. We are 2 surgeons with the same technique, same installation. It was a revisional surgery, and you can see there were some adhesion between stomach and left liver. I open the gastroepipelic ligament in the middle line of the stomach. It's easier to enter in the bursa lomanta. And I cut the gastroepipelic ligament, short vessel. You can see it's there is a lot of fat. It was difficult, of course. I don't hesitate to place a gaze. I cut the vessels on the antrum. And you can see there is, of course, sometimes pancreaticogastric adhesion. It's very important to remove it to dissect correctly the posterior wall of the stomach. Like this. You can see the pancreas. And it's very important to cut this adhesion to avoid any pancreas injury. When you see this tip of stomach, retracted stomach, this stomach is thick. I use green cartridge. It was a super obese man. I prefer use green cartridge. The anesthesiologist team introduce the gastric tube. And you can see left. I check the staple line. I check always between the 2 staple line. If there is a clip, I think it's very important to remove it. And you can see my movement. I stop the video with my left hand, left rotation to see the posterior wall. And with my right hand, I tract the fundus to be sure to remove the fundus. Of course, before a gastric section, the anesthesiologist, I check it, move the gastric tube to check. And I cut very slowly. It's a hard time for this section. I check between the 2 staple line every time. Like this. It's not a perfect sleeve. Huh? Like this. There is no clip. I continue. I track the fundus. In this case, I use a small rotation. Mobilization of the gastric tube. And I use very slowly the linear stapler. And you can see on the top, it was very difficult. I don't know where is exactly the esophagus. And perhaps I leave some part of fundus. And here, there is a clip. I think it's very important to remove this clip to avoid any failure of the linear stapler. I track the fundus. Mobilization of the gastric tube. And slowly. After gastric banding, it's very difficult to dissect correctly the fundus. We don't do the same surgery, sleeve or gastric bypass after gastric banding. I place the specimen in a bag and I place this stitch on the thinnest end to facilitate the extraction. And to finish, I oversaw systematically for 2 years. I avoid to place clip on the staple line because if you do a conversion in Roux-en-Y gastric bypass, perhaps you cannot cut transversally. A blue methylene test under pressure to check if there is no leak and to check if there is no stenosis, no gastric twist. And you can see on the top, perhaps I leave a part of fundus and I finish with a barb suture. And sometimes I fix the antrum to the gastroepipuric ligament to have a good orientation of the stomach. Thank you very much for your attention. And if you have any question.
Perfect. Thank you so much, Dr. Blanc. So now I think I will open up the floor for any questions. So if you have any questions, please unmute yourself and go ahead and ask. So anybody have any questions in the audience?
Okay, I have a question. This is Patrick. So, Dr. Blanc, I have a question regarding the sleeve gastrectomy. Because a few days ago, there was a webinar organized by IFSO. So the topic was the perfect sleeve gastrectomy.
Yeah, I saw it.
There was a French surgeon called Professor David Knocker.
Mm-hmm.
I think he's doing a study about Nelson's sleeve. So he claims that for this surgery, can solve the issue of reflux with sleeve gastrectomy. So I would like to ask if you have ever performed such surgery like Nelson's sleeve to prevent the occurrence of reflux with your patient. Thank you very much.
Jérôme, tu veux répondre en premier ou t'as pas écouté, Jérôme? Si? I never perform Nissen. I never perform Nissen sleeve gastrectomy. I think it was very difficult to do this technique, and the efficiency of the reflux is in evaluation. Is not sure. In my team, in case of reflux, I prefer to do a posteriori Roux-en-Y gastric bypass. We perform some Nissen sleeve because the patient have a previous anti-reflux surgery and we don't remove the fundus because it was very difficult. And in this case, the weight loss was not the same like a real sleeve gastrectomy. But I think it's not easy. What do you think, Dr. Dargent, about Nissen sleeve?
Really, I'm not fond of it neither, because it's contrary. I mean, the issue of hiatal hernia and reflux and sleeve gastrectomy is one of the most complex in the bariatrics, because it's a discussion that has taken place for more than 20 years. Because I remember well, during the era of the banding, there were many surgeons advocating to repair the hiatal hernia, so to close the cruise, etc. In the meantime, as they did the banding. If they claimed that if you didn't do that, you will have a huge failure, etc., etc. Didn't happen. So there are still many people even very good people who do the crural repair, etc., the hiatal hernia repair, in the same time as they do a sleeve. Whether or not they are right or wrong, I don't know. I don't know. I don't even care. I never do that. But there are arguments in favor or against that. That's not the issue. Repairing the cruise, repairing the hiatal hernia in the same time as you do the sleeve, it's okay for me. I don't do it, but it's okay. But doing a Nissen fundoplication at the same time as a sleeve, I would say 90% of the surgeons, 99% are very much, not only, it's different not doing something. I don't do the hernia repair, but I respect the people who do that. Don't mind. But doing the Nissen in the same time, so the sleeve is not the same. And it seems very well, it's documented that you have much more complications when you do that. Even David Noka acknowledged that. And even advocates, well, he's a good friend of mine. He's a good friend of Pierre as well. I mean, everybody knows David, but he overdoes it. He overdoes it. Really, it's too much. It's too much. It's not likely to be acknowledged worldwide, not likely at all. It's not because you have a good guy who speaks, you know, comes out and then is very confident, he knows everyone, etc. If he has a bad idea, it's a bad idea. So nothing to say about it. Nothing more. Yes, there's a few believers. There are believers in this technique. So I respect them as well, but not so many in France, believe me. Do you know any believer, Pierre?
No. I don't.
Even Patrick Noël
Yes,
is not.
but I don't. In France, some surgeons try to do Nissen sleeve gastrectomy, but I think it's very important to wait the data of David Noka.
It's very actually rare also in Saudi Arabia that we didn't do that. We didn't do Nissen with sleeve. It's very rare. But we got some patients who are actually had a Nissen. They are coming now for weight loss surgery. Mm-hmm. Those would be a bit challenging because what you're gonna do, you're gonna unwrap. Either you unwrap, then do the sleeve, or just do a sleeve below the wrap. So this would be challenging.
Bypass
yes,
is likely
in
to
this
be...
case, I don't hesitate to do a Nissen sleeve.
Yeah.
It's always the same with novelties. So you have people who jump into the novelties without thinking about it thoroughly, but others who are waiting till you publish results and people, you know, it's always...
But our experience with, can I share our experience with after sleeves, after banded, after a band?
Yes, Dr. Holly, go ahead.
Actually, I'm a big fan of one-stage procedure. So what we do in my practice, if somebody come with a band, I do it a single-stage procedure. I know there is a big argument or two-stage pros and cons for each procedure, but actually I'm a big fan of one-stage procedure. But there's few tips to be careful with, and it's when you come up at the angle of Hess where you shouldn't use thin stapler. Maybe you should go for thicker than what you use usually up there. This is the only thing I could add regarding that. And thanks for sharing your experience also.
Jérôme, tu veux répondre? Ton micro. Jérôme, ton micro.
Voilà. Okay. Can you answer first? Because I had been interrupted by a phone call, so I didn't get the question.
In France, the recommendation is a two-stage gastric remodeling and 3 or 4 months after sleeve or gastric bypass. But perhaps it's better to do one stage because when we remove the gastric banding, there is no adhesion between stomach and liver, and 3 months after the removing, sometimes it's very difficult. It's very difficult to show the good plan to remove the fundus, and the most difficult is the posterior wall of the fundus, because the fundus is fixed to the left crus, and we don't do the same surgery than a primary sleeve gastrectomy or primary gastric bypass.
What about what about removal of the capsule when you remove the band? Do you go really aggressive in removing all the capsule, or you just divide it anterior, or just excise the outer part? So what's your thoughts of that?
I remove the capsule just on the anterior wall. I cannot remove on the posterior wall. And the theory, if you wait between the remove and the second surgery, perhaps there is no capsule, but in real life, 3 months, 6 months after the gastric removing, you have sometimes capsule. And that is why in this case, I use green cartridge or black cartridge and oversew. But
Thanks.
it was revision surgery after gastric banding. It was very difficult, I think. It's not an easy procedure.
Absolutely, absolutely.
Maybe a slightly different opinion. I always wait 3 months, but you know, it's more habit than because some band removal can be tough. Not always, of course. I never remove the capsula. Never do it, but you know, I don't know if I'm right or wrong. Adhesions, you always have adhesions anyway, so whether primary or secondary. Some of the bands I removed, I know for sure that if I was in favor of doing a bypass or sleeve at the same time, I wouldn't have done it. So this is the reason why you know, when you establish a program, a schedule, so that you know that you have only band, because it's not the same schedule if you say, okay, I'm removing the band and at the same time I will do a bypass, and then I have 2 other operations, etc., etc. And in the end, you just remove the band and you don't do the bypass. You know, it's complicated to manage that. So this could be one of the reasons, maybe the weakest, but at least it's out there. And so no, I mean, yeah, several surgeons do it in the same time. I always did it in 2 times because we had a lot of bands to remove, a lot of them, believe me. So that, and the second point is that you can question, but there's something you have to take into account is the fact that a patient whose band has failed, which band has failed, is a patient that has been somehow more or less lost for follow-up for a while, at least a couple of years, or maybe often more than that. So you remove the band because you have to. It failed, and the patient is not compliant, etc. But before doing the bypass or the sleeve gastrectomy, you have to do something else. Re-evaluate your patient, prepare him again for another surgery, assess his psychological behavior, etc., etc. So 3 months is not too much. It's a good period of time to reassess your patient and bring him back into the track and evaluation process, etc. So that cannot be bad. Technically, of course, you can argue otherwise, but you know, psychologically, it's better, in my opinion.
Yeah, you did the T.
Okay, thank you very much. I think we have time for one more question. So if any member of the audience would like to ask a question to either Dr. Blanc or Dr. Dargent, please come forward.
So my question will be about the trend about the endoscopic bariatric surgery. because I know that you have some experience using the Apollo device. So it is a really minimal invasive surgery. So how do you see the development of such endoscopic procedures in the field of bariatric surgery? And what are the pros and cons of using such device? Thank you.
It's difficult to answer in a minute, but these are the outlines. I am a believer in this kind of technique, no doubt. I think every responsible bariatric surgeon thinks that there is a future in that, in this kind of technique, whatever the technique. Of course, there have been disappointments, especially, you know, the primary technique that's been out there for more than 40 years is balloon. So balloon is the gold standard of bariatric endoscopic technique. Still, balloon is somehow disappointing. It's short term, etc., etc. So that's one thing. There are other types of endoscopic techniques like endosleeve, like you know, the tube that you put into the jejunum, thermal ablation, etc. You name it. But plications seem to be the best. I mean, the most interesting for the future. Except if you staple all along. There was a stapling device. It's called Toga back in the 10 years ago. It failed. Well, it didn't fail, but it was not successful. And for the time being, plicating makes sense, absolutely. The point is, the way it developed with Apollo is a little bit disappointing because there are a lot of KOL who say that they have marvelous results that match surgery, but actually they don't. I wouldn't say it's a lie, but it's overstated, it's exaggerated. So they say, these very knowledgeable people, friends of mine, good people, they say they have very good results with the endoscopic plication. But when it comes to the average practitioners, I'm not so sure. I'm not so sure at the moment that plication is better than balloon. And it's way, way, way more expensive. Way more expensive. So it's 3-4 times.
What about laparoscopic plication?
Well, it's by and large, it failed as well. I mean, it's almost discarded and discredited around the world. Mm-hmm. Almost, virtually, it doesn't exist anymore. Scientifically speaking, it's been rejected by most. You have a point in speaking about that because, of course, endoscopic plication is supposedly a match to surgical plication. And why would something that failed surgically, more or less failed, would succeed endoscopically? That's a very good question.
Yeah.
Even more, when you plicate the stomach surgically, you plicate all the way, all along the greater curve. Sure. You agree with that? Otherwise, it's not a good plication. But when you do it endoscopically, you do not plicate all the way. You leave a remnant of fundus that is not plicated. And this is very weird, very difficult to understand why it's been. One of the things is that because you don't use the retrovision. If you don't use the retrovision, you cannot plicate the fundus. You just plicate a large part of the fundus, but not all of the fundus. So that's a tricky question, it's a tricky issue. I would say, nevertheless, I'd say it's quite interesting to continue in this direction. Very interesting. So I have a project of my own for that. It has some future, but it's too early to say. But I guess more money should be invested in that. There's not enough investment, studies, trials, experiments, because it's expensive to do, and it's not very. I mean, when you consider the price, it's at least between $4,000 and $5,000 for each patient, just for the device. If you take the fees into account, you have to pay more than $10,000 for a device, for a procedure that's not even sure to be successful. So let us be cautious, but it's definitely the way to go. But it's research and development for sure, for now.
Thank you.
Okay, thank you very much. So I think with that, we can conclude the webinar today. Once again, on behalf of Reach Surgical, I would like to thank all of the surgeons who are in attendance today for taking time off of our busy schedules and join our webinar. Hopefully the chats we have had today have been of interest to you. And I would also like to thank Dr. Dargent and then Dr. Blanc again for joining us. We are very, very grateful and honored to have had you join us today and then share your experiences with the surgeons in attendance. And hopefully we will be able to do this many more times in the shortcoming future. So thank you, everybody, and you have a good day. Thank you.
Thank you very much. Thanks.
Thank you very much. Very
Thank
glad.
you very much for the invitation.
Bye-bye.
Thank you.
Thank
Bye.
you. Bye.
Thank
Okay,
you.
thank you very much.
Bye-bye. Bye-bye.